All right, so I want to welcome everybody to the Cervical Spine Research Society second webinar of the year. This one's on cervical spine trauma, critical knowledge and methods to manage cervical spine trauma. We have special guest speakers, Allan Levi from the University of Miami and Alex Vaccaro from Rothman Institute. And our moderators is myself, Marcus Mazer from University of Utah, and Rory Murphy from the Barrow. So to plug our annual meeting, so the 52nd annual meeting and instructional course this year is in Chicago, December 11th through the 14th. We also have the sponsored journal, Clinical Spine Surgery for the Cervical Spine Research Society, and cervical spine papers are expedited through the review process when submitted to this journal. Applications for CSRS membership are open until September 15th, and these are our social media plugs. We also have all our webinars published on YouTube at the CSRS YouTube channel. And so we're going to discuss a case and then have Dr. Levi talk about management of spinal cord injury, followed by a Q&A discussion. And then we'll present a second case and have Dr. Vaccaro talk about the subaxial cervical spine trauma classification and its application in treatments, followed by a question and answer period at the end.
Thank you, Marcus, for that introduction. The main goal of this webinar is to help everyone who's trying to help a person with a spinal cord injury or a spinal cervical fracture. So whether you're new to helping people, a student or a resident trying to gain experience or about to start your night float, or if you're a spine surgeon who doesn't do much trauma, and even if you're a professor, we're hoping to give you some of the best research and spinal classifications and wisdom from Dr. Levi and Alex Vaccaro as well. So this is my case I dealt with this year. It's always a bad sign when the secretary from the ER calls you and just tells you at 1 a.m., just come in, Rory, just come in. So that was a bad start to the night. So I went in and there was 6 young people severely injured in a high-speed motor vehicle collision. So I quickly triaged the patients, and this young lady, unfortunately, she was Asia A C5. So I quickly assessed her within, I got there within 15, 20 minutes of being called. Her injury was approximately an hour before I was called. And we emergently brought her to the OR and had her intubated in the trauma bay before we brought her to the OR for airway, breathing, and circulation, and doing our basic ATLS protocol. So got her into the operating room straight away, and I immediately placed her in traction, which was able to reduce this fracture significantly. But I'd like to ask Allan and Alex, what do you think of this fracture and what would you do in this situation?
Start with airway, breathing, and circulation, making sure her blood pressure has a MAP of 85. Consider this an absolute emergency. I know you said it was 1 o'clock in the morning, and a person may have the attitude, well, it's 1, I'll see her at 8 and figure it out. And these are emergencies. They've got to be taken care of quickly, just like you did. There's significant instability. There's significant cord compression, both of which need to be addressed, and both of which could be addressed in the operating room. And then we can have a discussion about sort of what's the best approach, front, back, both. And I will leave that to Dr. Vaccaro maybe to discuss.
So I totally agree with Allan's position. Today, the most important thing when you have a patient like that is to get the blood pressure up, perfuse the spinal cord the best you can, stabilize the patient's vital signs, and then stabilize the spine. As Rory said, he put the patient in traction, which is important. And stability can be conferred through traction, or it can be confirmed in an intraoperative setting. Once that is done and you have an understanding of where the injury lies, then aggressive surgical intervention. And I always have this adage that I tell my residents and fellows: when I operate early, I have seen some miraculous recovery in neurologic function. But if I have an opportunity to operate late because the patient was delayed in getting to me, those miracles are less often. So I think that the way this is being managed is exactly the way you should proceed.
Next slide, Maria. So I went anteriorly and did a corpectomy. And generally, I use, if it's traumatic or degenerative, I use allograft. So I fashioned a fibula strut into an allograft and utilized that. And I got an excellent reduction realignment with just the anterior approach. But I did go posteriorly as well for decompression and stabilization. Unfortunately, on the anterior portion, there was a sagittal split fracture, and there was also a linear durotomy, which I had to manage intraoperatively with a dura repair. And there was a fracture. So the fracture had caused a significant dural tear. Do you see this often, Allan or Alex, or how would you deal with that?
I'm going to comment on, so you said a vertical split fracture of the actual vertebral body. Is that what you're referring to, Rory?
Correct. And I did my corpectomy, and then I had the always disappointing visualization of CSF and a centimeter longitudinal durotomy immediately behind the fracture from the fracture line. So, Maria, can we go back to the last slide?
So I have seen that. So it's interesting. I have a few little tricks in that setting. So the number one goal is obviously decompress the spinal cord, control the leakage of CSF fluid. Once that's completed, you have two options. It's not, you had a vertical split. If you can repair it, it sounds like you had the ability potentially to repair it. If you don't have the ability to repair it, I just lay a little bit of Duraseal. I put a Duragen patch, a little bit more Duraseal, make sure it doesn't cause any compressive lesion, because the last thing you want to do with the old Duraseal is use it in this setting. With a new Duraseal, I'm very skimpy on how much I place on it. Then I lay my graft on top of it. And you're both, the vertebral body above and below were intact, right? You didn't have any split. You didn't have any injuries to those vertebral bodies, right?
Correct. It was just C5. So C5, C4, and C6 were the vertebral bodies were intact.
Gotcha. So then I would apply fixation. The thing about the drainage in that situation, what I do is I try to do the best repair possible. And then I will place a drain, and I'll tunnel a drain subcutaneously all the way distal to the clavicle. So when I eventually pull that drain, which I'm going to keep in for 5 to 7 days, I'm going to be able to pull it and prevent a CSF fistula from occurring. So in a situation like this, now, if I'm lucky, that's it. If I really feel worried about it, I'll place a lumbar drain on top of that, which is always the safe way to go. I'll do a lumbar drain, decrease, intradural pressure, plus, allow my repair to repair. So if I felt I had it stopped in the operating room, I wouldn't put the lumbar drain in. If I didn't, I'd use both a superficial drain. I'd have a lumbar drain placed. And then you did the right thing. I would just, go posteriorly in this to give it further stability. That's how I would manage this.
Yeah, I mean, I agree. Collagen substitute of some kind. I'm not a big glue fan, but I would definitely use a collagen substitute. And, fortunately, most of these will heal without a problem because of just the blood and stuff like that. It's more of a problem if it's an elective case. I think you just need to be careful not to over distract. These are so unstable. It's so easy to put an oversized graft in. And then I would also go posterior, and I would try to stay, my personal preference is I would try to stay short on the posterior supplementation.
So in this scenario, you believe we may be able to just do 4 to 6?
Yes.
Well, I used a Duragen, and I used a fibrin glue, and I did put the lumbar drain in. I was going to put the lumbar drain in anyway to reduce CSF pressure. And if you don't, would you like to talk now or later about your management with lumbar drains for spinal cord injuries?
Yeah, no, I think the lumbar drain has a dual purpose here. It's to reduce the CSF pressure at your dural repair, but as was alluded, that will increase the spinal cord perfusion pressure, so it'll have a dual benefit. So I think a lumbar drain is a great idea in this case.
And how do you manage that drain then? Because there's some excellent protocols from UCLA and Hopkins. How do you manage it?
I mean, usually we try to drain 10 cc's an hour if we're going to be doing it for spinal cord perfusion. We have our own separate protocol, so we tend not to do CSF drains for every spinal cord injury. But as you said, there's several good published protocols.
So in our case, we brought this young lady to the OR straight away, decompressed her. I did do two above and two below. I agree. In a young person, probably one above and one below would have been sufficient. I kept her mean arterial blood pressure greater than 85 for 5 days. What's your view on this, and Alex? Is it you do 3 days, 7 days, 5 days?
So we always shoot for 5 days. In reality, every study we've ever done is that we miss the mark several times in a day. But I shoot for 5 days. If they plateau at 3, sometimes I modify it. But our goal is always 5 days. In reality, if you look at the literature across the board, people fail to maintain those goals. But I think that's what you should shoot for.
Rory, there's a question about why you skip C7 posteriorly.
Good question. I think there's a lot of debate about where to stop. I got better fixation. I generally skip C7. I guess you could stop. You could do 3, 4, and 6 and 7. There was a small on the axial CT. The lateral mass of 6 and 7 were affected, so I decided to go down lower. But potentially, you could stop at C7 too.
And the question about the lumbar drainage. How any protocols? Is it 10 cc's an hour for a certain number of days?
Yeah, that's probably best answered by Rory because we're not active. We have a DoD grant, but we don't typically employ it, on every patient. So what did you do, Rory?
Yeah, this one I did 10 cc's on the hour every hour, kept it simple. But Sanjay Dal and others have published on titrating the drainage against the mean arterial pressure and other mechanisms and techniques. So I guess it depends on how advanced and how competent your team are in the ICU or the area that your patient is being treated.
And there's also a question from the audience about posterior decompression or perhaps even a expansile duroplasty. Would you consider that in this case?
Yeah, again, that's part of a research protocol that has been submitted. I'm not sure I'm sold on the duroplasty when you have realignment. And in this case, I bet if you did a post-op MRI, you probably would see CSF reconstitution. But again, it depends on how much spinal cord swelling there is. And the question is, does a duroplasty give you more room for the cord to swell, or would it be better to even do a peel incision? And there's discussion about what's the value of that, more in thoracic cord than cervical. But again, these are all great research questions that are out there.
And Allan, what about putting there is some potential benefit or some interesting research being done on putting scaffolds in. So bioactive scaffolds into the area of injury or zone of injury. What's your view on that?
Well, we'll actually talk about that briefly. That was a trial in thoracic and thoracolumbar fractures, and the results are pretty good, I would tell you. A lot of Asia conversions in that trial. But the question is it the scaffold or is it simply opening the PIA and letting the bad, macrophages and blood clot be expelled? And that's not clear. But it's never been done in cervical. It's always been thoracic or thoracolumbar.
Excellent. Our patient and their family were very gracious, and they did enroll in your study on the DoD hypothermia trial. So they were enrolled in that trial to hopefully help other people in the future. And then the patient did improve to Asia B from an Asia A, and we're still following this young lady and hoping that she improves.
Awesome. Well, we'll talk a little bit about that in the talk to follow.
Well, I look forward to, I think it's the perfect time to move on to your section now.
Well, it's a pleasure to be here with you this evening as part of the CSRS webinar. I thank our moderators, Dr. Mazur and Dr. Murphy, for the invitation, and it's always a pleasure to be able to speak alongside my colleague, Dr. Alex Vaccaro. We're going to be speaking about critical knowledge and methods to manage cervical spinal trauma, and I'm going to be focusing on the management of spinal cord injury, and in particular, cervical spinal cord injury. These are my non-relevant disclosures, and probably the most important slide in the deck, showing a post-mortem sagittal image of a spinal cord injury. And the take-home here is that there's often areas of dead cells centrally that any neuroprotective strategy won't resurrect. But there is often some white matter around the area of injury and occasionally gray matter that can be helped by neuroprotective strategies. But this is going to be a limitation in some of the neuroprotection that is afforded, and it'll be evident when we go over the individual protectants. We're going to talk about methylprednisolone, riluzole, and modest hypothermia. Starting with methylprednisolone, a lot of excitement in 1990 when this paper came out in the New England Journal of Medicine. It was felt like we really had a cure for spinal cord injury, and it was based on the results of a multi-center, blinded, randomized trial that looked at control versus methylprednisolone versus naloxone. And there were significant differences in some subgroups in recovery that persisted at 6 weeks and 6 months. However, one of the problems with the study is that it was a relatively small number of people in this subgroup analysis in which there was improvement, and that there was a post hoc decision to look at less than 8 hours. When the whole group was looked at, there wasn't a significant effect, and it seemed to be limited only to the group in less than 8 hours. Because of significant concerns about the results of the study, there were many papers written, many guidelines written. In 2003, it was felt to be an option. In this paper from 2013, it was essentially not recommended. And a more recent paper published by Geisler and Failings in JNS in 2023, essentially the conclusion was that administration of methylprednisolone after spinal cord injury does not demonstrate any enhancement in neurological recovery at 26 weeks. I can tell you in our level 1 trauma center, we haven't really used it since about 2010. Another area or drug that's of interest as a neuroprotectant and has been published most recently is riluzole. And an extensive amount of work has been done by Dr. Failings, AO Spine, and the following authors looking at safety and efficacy, again, in an acute spinal cord injury as a multi-center study. And essentially, the inclusion are as above 18 to 75, Asia A, B, and C, looking at cervical injuries. And when you look at the results of both the phase 1/2 and the phase 3 study, there was no safety concerns. It was difficult to recruit patients for the phase 3 study, in part due to COVID, but there was no obvious beneficial effect. There was possibly an incomplete subgroup effect. The other observation is that giving these oral riluzole medications, there was considerable variation in the plasma levels, and it was felt that in those patients who achieved adequate plasma levels, there was more of a suggestion of improvement. And this is a continued ongoing studies that will require further elucidation, I would tell you. An area of interest of mine and at the University of Miami and the Miami Project is that of cooling. of the central nervous system, and in particular the spinal cord. And there's been a number of studies that have looked at cooling and the beneficial neuroprotective effect in a number of animal models. We've been using cooling here since 2012, and we've been doing systemic cooling via central venous catheter that's inserted into the jugular vein, and it's a closed loop system where cold saline is circulated through these balloons to cool the passing blood, and you can very precisely regulate systemic temperature. Based on a local SCI protocol that we developed, and no patient got methylprednisolone, patients with cervical spinal cord injury were cooled, that their blood pressures were maintained with MAPs of 85, and they were entered into a prospective registry. This is from one of our early papers in 2009 showing that cooling equals cooling of the spinal cord. When we put a Lycox catheter into the subarachnoid space and cooled people down to 33, you can see systemic cooling equals subarachnoid cooling. This is the protocol that we developed, which is basically a 48-hour protocol of keeping the temperature at 33 degrees. It takes a little while to get there. It takes a little while to rewarm, and it's important to slowly rewarm the patient. We published our results of over 50 patients over an 11-year period, and we felt like the ASIA outcomes were better in the cooled patients compared to historical controls, and that's what this slide shows. And when we presented that paper or those results in a journal article back in 2012, we got recommendations from the spine and peripheral nerve section that there was grade C or level 4 evidence supporting its use. We felt like it would be important, if we were really going to get this type of treatment to our colleagues, it would be important to show in a prospective randomized study, multi-center, and look at cooling versus normothermia and see if that would be helpful. We were lucky enough to get DoD funding. These are the inclusion and exclusion criteria. You can see that we're looking at cervical levels, ASIA A, B, and C. Patients are 18 to 70 years old, and there are several exclusion criteria. And you can see where we're at in terms of enrollment. We want to get 120 enrolled patients, so we're about 60 to 70% the way there. Most of the patients have been enrolled in our center, and we are still enrolling. We certainly were affected by COVID, and this is the most updated results in terms of enrollment per site and how many have been enrolled in each arm. These are some of the data on the hypothermia versus the control patient, and we're carefully looking at outcomes in terms of ASIA conversion. A little bit too early to tell whether there's benefit or not, but I would tell you early results seem promising in terms of the ASIA conversion rate. So we talked about hypothermia. We also need to discuss, are there cell replacement strategies that might be available? And we've spent a lot of time here at the Miami Project and in other centers looking at how we can replace damaged cells within the spinal cord. I'm going to talk a little bit about stem cells, Schwann cells, and spinal cord scaffolds. There's been a lot of interest in using embryonic and fetal-derived stem cells because of their potential to actually turn into neurons, while adult mesenchymal stem cells can be beneficial, but they can't actually replace the circuitry in the lost spinal cord. We were involved in a Stem Cells Inc. trial a few years ago looking at transplanting fetal stem cells in chronic cervical injuries with immunosuppression. It was basically a dose escalation study and looking at injecting higher doses, progressively higher doses of stem cells in and around the epicenter of a chronic cervical injury with immunosuppression using tacrolimus. looking at the blood levels, making sure there wasn't untoward effects. I mean, this was really the first in man type of study injecting stem cells into the cord. You can see in our patients here, pre-transplant and 1 day post-transplant, while you can't see the cells, you can see that there is fluid that has been injected both above and below the area of cord injury. And one would question, well, that's got to be potentially a dangerous situation. However, you can see from the upper extremity motor scores, there was no significant change post-treatment. And almost certainly that has to do with the fact that you're injecting cells into areas of Wallerian degeneration rather than actively functioning cord. So we basically showed in this multi-center study that it is safe, that we definitely got improvement in certain subset of patients. But unfortunately, with this study, the degree of improvement was at a magnitude below set by the sponsor. So it really didn't progress to the next level. There was about 2 other competing stem cell studies that were going on at the same time, which I would tell you showed very similar results. At the Miami project, we're very interested in autologous human Schwann cell transplantation. The reason why we're so interested is because it allows you to transplant cells from oneself and not depend on immunosuppression. Schwann cells are very interesting because they secrete growth factors. They can provide a scaffold for regeneration. They've been shown to regenerate both CNS and PNS axons. So there's robust data in numerous animal models, monkey, pig, rat, mice, where the introduction of Schwann cells, the green cells in this image, can result in functional recovery and axonal remyelination. We did a study looking at safety in a dose escalation study here in thoracic cord, in subacute injuries, looking at sural nerve biopsies, isolating the cells, and then transplanting the patient's own cells back into the injured cord. This is showing the number of patients screened, enrolled, and transplanted, looking at the dosage of the cells. And then ultimately, what we found was there was no adverse effects. We completed that trial in 2015, published it in the Neurotrauma Journal, and we showed some improvement in sensory function locally, improvement in motor function locally, and had 1 patient improve in 1 ASIA grade. Another study that we did was looking at both cervical and thoracic chronic spinal cord injury, looking at Schwann cell transplantation into a small cyst within the cord. It's interesting that the trying to find the ideal patient with a small cyst, whether in cervical or thoracic, can be challenging. And that speaks to how many patients we screened during this study, 412, to actually get 8 patients to transplant. This is some of the data on the etiology, age, and demographics of the patients transplanted. This is showing an intraoperative picture, as well as pre and post MRIs, post-transplantation. We'd have to make a small peel incision over the cyst, and we would inject a cyst-filling dosage of autologous Schwann cells. Again, this study showed no untoward effects, some improvements locally in patients who received the transplant. And again, remember, these were chronic injuries, some as many as 15 years post-injury. Another area that's a little different than cellular transplant, but is scaffold transplants. And then this was, again, done in the thoracic spinal cord, part of an INSPIRE study looking at acute injuries within 3 days post-injury and making a peel, an incision, and transplanting a scaffold within the cord. This was a very interesting study with pretty reasonable improvements, especially in a patient population that has a relatively poor prognosis. The results were published in Neurosurgery. And of course, limitations were small sample size, no control group, and it was limited to thoracic injuries. But again, an area I think that is potentially exciting. Finally, we're going to talk a little bit about future directions that involve brain-computer interface work and epidural stimulation. There's really been some wonderful work done by Susan Harkema at Kentucky, looking at epidural stimulation, even in complete subjects, to improve walking, autonomic, and sexual function. And that's been published recently in the New England Journal of Medicine. So again, an area of great hope. This is a patient of ours who was implanted with a cortical surface electrode to stimulate the motor cortex, which he was able to harness those cortical waves to move a hand device and allow him to open and close his hand and grab objects, even control a car. So it's a part of the brain-computer interface work that was the difference being this was all Bluetooth as opposed to having something sticking out of the cranium. And there's certainly been a ton of excitement about the recently transplanted Neuralink patients with the Neuralink electrodes that actually penetrate the cortical surface, giving sort of higher resolution in this area. So again, a great area of excitement. And finally, and I'm sure my colleague Dr. Vaccaro will talk about this, but surgery can also be important in spinal cord injury and recovery. And certainly there's been some great work by my colleague looking at early decompression for cervical spinal cord injury recovery. And there's certainly more and more data. There's a paper published in 2012 to suggest that early surgery improves patient outcomes. And this was a paper that was published in PLOS One. And so this study basically showed that 25% of patients who were decompressed within 24 hours of their injury improved by at least 2 grades, while only 4% of patients who received delayed decompression had a similar improvement. The 1 grade ASIA improvement was the same in both groups. There's always, potential criticisms of the study, but it was a well-done prospective study that the surgeons determined whether to do early or late surgery. And I will let my colleague, Dr. Vaccaro, speak to that study as well. I really appreciate your attention. It was really great being part of this webinar.
Thank you very much, Alan. That was fantastic. I get asked all the time in clinic about what stem cell therapies are available or what other options are available. So that was a really excellent summary that I can share with people. One question we got from the attendees are, if you have a person with an ASIA A injury, do you decompress or not? Or how do you counsel a family with ASIA A injury? And when do you do an MRI and not in such cases? Every patient, unless they have, from my practice, any patient with an ASIA A injury, unless they have another life-threatening injury and they're severely unstable, I'm bringing them straight to the operating room. And one thing I'm very proud about we have here is, since I've started here in this Level 1 Trauma Center, we can do a quick screening sagittal T2 MRI on the way from the trauma bay to the operating room. And it only takes about 5 minutes to do the MRI. So we can bring them from a trauma bay, as long as they're stable, to the MRI, do that 5-minute scan. That allows me to plan the surgery better and then straight up to the OR. So we have them from the entry into our trauma bay to the OR within 45 minutes to an hour, including basic resuscitation, ATLS protocol, getting a CT, and getting a very quick 5-minute MRI. So I always will decompress them immediately. ASIA A, B, C. What's your thoughts, Alex?
I totally agree. I've been very aggressive, and I've been criticized for being aggressive in decompressing ASIA A's. So again, if the patient's elderly, there's a potential for permanent vent dependency, or they have a critical illness, that would be something that I would then not do that. But in general, I agree with you for all the different, even with the post-traumatic CSF flow, biomechanics, I would decompress early. I strongly believe on it. And I strongly believe in early surgery, like you said. We've participated in all the stem cell studies. I don't have much experience. It's always interesting to listen to Allan speak about it, because I think that down in Miami, they have the most progressive spinal cord injury research center. And it's good to see that progress is being made. Allan, you stimulated my interest in Schwann cell transplantation. We're participating in, intracranial sensors and so forth. We're working on that in our lab at Jefferson, which is good. So hopefully we'll continue to make progress in these areas.